and I am glad to turn this next section over to one of our new board members, Dr. Sandra Jones, and she's going to walk us through our research questions, all the many questions that we had. Sandra is a primary care PNP with 30 years of experience in clinical and research settings caring for children, adolescents, and young adults living with HIV and cancer. She works at St. Jude Children's Research Hospital in Memphis for the Transition Oncology Program. Welcome, Sandra.
Thank you, Adele, and hello, everyone. As a clinician with many years of research experience and inquiry, I am especially excited to share the questions that PNCB, our dedicated volunteers, and our consultant partners developed to move our research agenda forward. Through our conceptual work with Christopher Butcher and our long history of certificate renewal programs, many lines of inquiry emerged through discussion with leadership, staff, and volunteers. We will introduce our questions in this segment, then after lunch, move to how we gathered evidence and began making decisions. First, we wanted to understand if a mindset unique to pediatric nurses existed. We wanted to solidify not just a set of competencies, but a way of approaching care for children that sets certificates apart. As we all know, children aren't little adults. We use the mindset concept as a focal point for our exploration of ways certificates currently demonstrate competence. Next, we needed to confirm what was required in the healthcare ecosystem. How do employers measure competency on a regular basis? Is there a formal system with set requirements and routine checkpoints as we would expect in the hospital environment? Or are certain settings more informal in their validation? What proof is recorded by the employer? And could that proof be used by PNCB in the future to align employer needs with our research requirements or options? Do employers value some company activities over others? The same applies for regulators, especially boards of nursing. We know that most states rely on PNCB verification of nurse practitioner recertification as part of their own renewal process. But many states now accept proof of RN recertification as credits towards RN license renewal activities. We're also aware that many states now require opioid and abuse education requirements. We're aware of many employer requirements such as life support training and faculty-specific classes and assessments. But how do they really assess and evaluate overall competence of any employee? What activities contribute to evaluation of job performance? Were there any new requirements or options we needed to know about? Circling back to our mission and those who want certification to ultimately help, we needed to understand what families and the public expect regarding continuing competence. As we know, the public is not usually dialed into the concept and implications of certification, and there are challenges in reaching this audience. But we know that when care is delivered, families want their children to receive care from a nurse who has up-to-date knowledge. PNCB's system is rich with data. We can see that nurses use to recertify at both micro and macro levels. But thinking back to our earlier questions, how does what they submit to us align with requirements beyond PNCB? Do employers and regulators value our research requirements and range of options? Which leads us to consider the role clinical practice plays in continuing competence. And does clinical practice mean direct hands-on care exclusively? Many other nursing certification boards require active practice to renew a credential. But as you learned earlier with Maggie, PNCB stepped away from that requirement in the past. Just as nursing has evolved in so many ways in the past decades, nurses also grow in their careers. Pediatric nursing professionals become administrative leaders, directors, and chief nursing officers. They are hired for titles unheard of many years ago, like informatics specialist, quality integration consultant, or magnet program director. and they can subspecialize in any system or condition related to pediatric health. But when nurses specialize or advance, does their core pediatric nurse or NP knowledge erode? The foundation of a credential is the exam content outline upon which some of our certificates tested decades ago. How much erosion is acceptable? And as nurses grow in their career beyond core content, should certification board require retesting? What do certificants and other stakeholders think of retesting? As we mentioned earlier, PNCB requires annual recertification for CPNs and CPNPs and 3-year recertification for those with our added specialty PMHS credential. Should PNCB make any changes to these policies? What do certificants and other stakeholders think about new activities like an assessment that determines what their C content should be? Would a reflective exercise help to shape or document the activities that nurses engage in for continuing competence? That's a lot of questions, but we had to ask just a few more. Certification boards are required to conduct routine job task analysis studies every 4 to 7 years. They're called JTAs. Respondents actively holding relevant credential are invited to participate in an in-depth survey. Results from these studies ensure that exam content accurately represents current practice for that credential in the United States. Boards are allowed to ask additional questions in the surveys. In our recent JTAs, we asked the following. Does your primary employer have a system of career advancement? Our goal with this question was to find out if there were linkages with career ladders. Does advancement in a career ladder imply continuing competence? We also asked, if you spend more than 50% of your time in a pediatric subspecialty, please select your subspecialty. Pediatric nurses are well-rounded. We often get extensive write-in comments describing their subspecialties in great detail. This question's goal was to give us a concise portrait of how many respondents are working in a subspecialty and what their primary subspecialty focus is. We wanted to know if certificants had subspecialized and understandably moved away from some knowledge elements of the entry-level exam content outline. Finally, we asked, if you were to provide care for pediatric patients outside of your subspecialty, would you need additional training to be confident? Here, our aim was to assess to what extent the nurse or nurse practitioner recognized their own loss of knowledge. We wanted to explore the concept of forgetting or affluence. That is, forgetting content or how to perform a task, and when content becomes obsolete and no longer relevant.
We will walk you through some of our research outcomes now and the evidence gathered for our next steps in the process. Presenting with me are board members Amanda Vickers, lead advanced practice practitioner working in school-based telemedicine in San Francisco, California, and our primary care PNP at large, Donna Bijani, secretary and CPN at large member and clinical nurse educator at Children's Hospital of Orange County, and Dr. Carly Byrne, another of our CPN at large members and a clinical nurse specialist at Legacy Health Randall Children's Hospital in Portland, Oregon. In PNCB's early work on this project, we realized we needed to develop a statement that described the qualities embodied by the pediatric nurse, or PNP, as we've described and alluded to before. What sets us apart from nursing professionals in other specialties? What characteristics, knowledge, skill sets, and competencies should they exhibit? This statement would represent an up-to-date, holistic understanding of the pediatric nursing professional and have implications for our recertification program. After small work groups drafted core language for a series of constructs, we refined the language and asked volunteers in nursing leadership, research, and other arenas to review the draft. We asked if it resonated and if anything was missing. Several edits were considered and made to expand it, and then the mindset itself was ready for certificate validation. We included the mindset language both in our 2019 in-depth survey for certificates and our employer and supervisor version of the survey later. More than 12,300 stakeholders validated the core and expanded statements. Stakeholders were provided the opportunity to add comments, which were used in minimal final language edits for the expanded statements. Even though the mindset comes later in our timeline of outcomes, we wanted to present it first, because this is what a certified pediatric nurse or nurse practitioner brings to the task of expertly caring for children, adolescents, and young adults. In many ways, the mindset has really become the glue connecting the other research findings, which are up next. Of course, we've talked about how children are not little adults, and pediatric nurses know the basics, particularly the special understanding of emotional, social, and spiritual and physiologic development of children, and they know specific childhood illnesses that only children get, as well as precise pediatric medications, dosages, and therapies. I love the part about the pediatric nurse promoting healthy family interaction. Just let you read it, because the expanded slide. This one is very meaningful to me because, right, I think all of us pediatric nurses and nurse practitioners can see ourselves in this, but because it was validated by employers and supervisors, I think it has special meaning, because it's those people saying, yes, this is what you bring to the table. We thank you for looking at the mindset with us, and I know that there is a copy in your packet, but this last part too, what makes a pediatric nurse different is that they represent the best resource to support optimal child health. We hope you agree. Now I will turn the presentation over to Amanda, and she's going to carry on with more of our findings.
Thank you so much, Adele. The PNCB's next exercise was to understand perceptions of forgetting or obsolescence of foundational exam content as their certificant's career grew over time through advancement or specialization. Our goal was really twofold. After the initial certification exam, does a certificant need to demonstrate competence in all areas of the applicable current content outline? And is there a particular way that competency must be demonstrated in order to give confidence that a certificant is able to function competently? In small group webinars, we asked CPN and primary care PMP and acute care PMP volunteers who were subject matter experts to reflect on each task or topic listed in their certification exam's content outline, which is used for entry-level pediatric nursing professionals. This is just a portion of the worksheet used to record those responses. On the worksheet, there was a section for each competency area of the content outline, and participants were asked these 4 questions. What is the shelf life of a competency area? Is this competency area core to the credential? Is there a preferred demonstration mode for this competency area? And finally, are there existing components of the PNCB's recertification that allow effective demonstration of this competency? What we learned from these exercises can be summed up in themes of divergence and agreement. Each credential has different characteristics with respect to specialization and advancement, and there's no one-size-fits-all across all 3 certifications as certificants grow in their careers. Each group of certificants has a different perspective on the concept of core competencies. While most competencies in the exam content outline were considered core to continuing competence, some were actually not. Current research activities do not universally provide an opportunity to demonstrate competence, particularly for competencies that require a particular skill or attitude. But certificate groups didn't share the same level of agreement regarding the extent to which skills-based or attitude-based assessments were necessary. However, there were many areas of alignment. First, there's a possibility for any of PNCB's research components to serve as an effective demonstration of competence. A significant portion of the competencies of some credentials may be enduring enough that formal assessment following that initial exam may be unnecessary. A written recert exam to honor specialization is probably too complex to be feasible. Lack of alignment between recert components and competency areas may need more explicit alignment and validation. A key outcome is that our key questions proved relevant, and this meant that our hypotheses were ready for testing via a larger stakeholder input. So to bring our lines of inquiry to a larger group, we included new questions with our routine job task analysis studies. And again, this exploration focused on the CPN, the primary care PNP, and acute care PNP credentials. In 2017, we asked primary care PNP respondents, 1, does your primary employer have a system of career advancement? 2, if you spend more than 50% of your time in a pediatric subspecialty, please select that subspecialty. And this allowed us to classify respondents as either generalist or specialist. And then we asked the self-identified specialist, if you were to provide care for pediatric patients outside of your subspecialty, would you need additional training to be competent? We asked the same questions to our acute care PNP respondents in 2018. The data showed that for each PNP group, a little over a third would actually need additional training to be competent. For CPN respondents in 2016, a system of career advancement is more thoroughly embedded in the RN role. In this earlier study, however, we asked a different question about competence to understand levels of proficiency among the pediatric age range. Overwhelmingly, CPN respondents either maintained or increased the depth and breadth of their knowledge. And this indicated to us that nurses are not stagnant in their acquisition of knowledge, and that we needed to learn more about the clinical ladder and competence. And so now we'll begin our journey into the ethnographic research. Phase 1 consisted of interviews to understand how different stakeholders perceived certifications. Here you can see the range of interviewee roles. Again, the CPN and the 2 PNP credentials were our focus area. Interviewees in pediatric nursing came to their careers and make career decisions, including certification, in many ways. Sometimes the ways they arrive here are unplanned or based on life stages, experiences, learning styles, and personality. One of the key drivers cited, for example, was the need to balance career with family obligations. These widely divergent drivers do make it a challenge for professionals and their employers and education providers to map out a clear path of advancement and success. A few interviewees had always known they wanted to work with children, but not necessarily through nursing. However, pediatrics did become their mission in life with a fierce commitment to serve children and families, and pediatrics is a calling that inspires and motivates them on a daily basis. Based on the initial constructs drafted by the time of the interviews, interviewees confirmed that a pediatric mindset exists. And there was also a consensus that lifelong learning was a key part of the pediatric nursing and that our specialty has a distinct culture. Underpinning this culture are intangible attributes and a unique mission to treat children and the entire family. However, it became clear that the evolving mindset was much richer and deeper than the draft constructs. Additionally, interview feedback helped us understand that we need to explore motivations, learning styles, aspirations, and needs beyond our current research options and CE programs. And the PNCB is well positioned to help address these needs and should consider how we can support the specialty, perhaps through new competencies or innovative and engaging ways to help certificates grow and continue learning. The themes in the interviews contributed additional core elements of the mindset, such as empathy and teamwork, a family-centered focus, and relationship building, as well as relationship-based leadership. Mentorship and leadership development also emerged as potential elements. Now, we've been focusing on the nurse perspective, but we also wanted to share several quotes from the parent who was interviewed. She was the mother of a 14-year-old cancer patient and not really aware of her son's nurse's credentials except in very broad terms. Although she later learned that many of her son's nurses had certifications and credentials, those credentials were not a factor in her satisfaction with the care that her son received or the trust she had in the professionals in charge of his care. She said, "There was never an instance when I had no confidence in someone's skill or experience. I felt that all the pediatric nurses knew what they were doing, They seemed experienced with any situation. There was no hesitation, no panic, just calmness and warmth. They also valued their own knowledge and competencies. I often heard them complimenting each other when they were chatting outside in the corridor outside of patients' rooms, and this increased my faith in them. As you can see from these quotes from our interview, it is clear that empathy, teamwork, family focus, and relationships form the core of her experience with pediatric nurses. The interviewees also provided feedback on certification itself. All nurse interviewees sought and obtained multiple credentials and/or certifications, and all expressed a passion for continuous learning. Most agreed that the value of certification would increase if direct evidence-based links could be established between certification and either career-based or patient-centered outcomes. But a surprising finding was that interviewees held widely divergent views about the value of certification itself. Although most valued it, perceptions of that value ranged from seeing the PNCB certification as essential all the way to one certificant who doubts the value of any certification at all, including presumably the PNCBs. The divergent drivers we mentioned about how people come into pediatric nursing surfaced as a challenge when supporting nurses. With all the various influences impacting career decisions, how can nurses, employers, and education providers map out paths for advancement and success? Interview participants indicated that in addition to developing competencies to improve performance in their current position, essential motivation for continuous learning and certification is to identify entirely new roles and paths for themselves that make use of their talents, meet needs related to their current position or their role or stage in life, or enable them to take a different direction as a result of the lessons learned. And so from here, we'll move on to phase 2 of the research, and I'll turn it over to Donna. Thank you.
Thank you, Amanda. For phase 2, the consultant interacted with CPNs, CPNPs, and their employers and colleagues. Phase 2 research sought to understand how certified pediatric nursing professionals add value to a practice setting's final product, which is optimized patient care. In addition, phase 2 interviews took a preliminary look at what role, if any, certification and recertification play in either directly or indirectly creating value for non-nursing stakeholders, including other healthcare providers, patients, practices, and institutions. To accomplish this, the consultant gathered indirect input from non-certificate stakeholders and influencers who are part of the value chain of pediatric nursing and pediatric nursing certification in a representative practice setting for each credential. For CPNs and acute care CPNPs in a hospital setting, a wide range of healthcare team member roles existed for interviews. Titles and responsibilities included Chief Medical Officer, Pediatrician in Chief, Section Chief Chair for Pediatric Critical Care and Nephrology, Director of Clinical Education, Marketing, Director of Community Relations and Patient Experience, Pediatric Dietitian and Pharmacist for Pediatric Intensive Care Unit. Several interviewees also held academic posts in addition to their medical roles, including Associate Professor of Pediatrics, Instructor of Pediatrics, and Vice Chair of the Department of Pediatrics at a university. For primary care PNPs, the private practice or outpatient setting does not usually offer a diversity of roles. Interviews were conducted with the practice's medical director and nurse manager. Most interviewees here describe themselves as either pediatrician, nurse, or nurse practitioner. This was expected due to the type of practice setting. While phase 1 interviews set the course for our inquiries, phase 2 was a deeper dive into the attributes and cultures of pediatric nursing professionals. Gathering viewpoints of non-nursing pediatric providers and administrative stakeholders for the first time in continuing competence research help fill a gap in the understanding of attributes that make up the pediatric nurse mindset. Previously, the views of the stakeholders who work with and rely on pediatric nurses in various settings had not been examined in detail. By tracing pediatric nursing and certification value chain through 3 practice settings, The interviews added vital context to a real and perceived value of the pediatric nurse mindset in action and how certification and the demonstration of competencies actually impact daily life for all people in these settings. This context includes a holistic view of the role and value that pediatric nursing professionals and certification bring to the healthcare setting in which they operate. So our 3 questions were, number 1, how does the pediatric nurse mindset, certification, and demonstration of competencies impact the daily professional lives of pediatric nurses, nurse practitioners, and their non-nursing stakeholders? 2, how do other stakeholders define and experience the unique attributes and competencies of pediatric nursing professionals? And number 3, how do non-nursing stakeholders define and experience the value of pediatric nursing certification for themselves? As interviews unfolded, themes and consensus emerged around these 5 areas. All stakeholders interviewed spoke about how the care of children requires special understanding of their developmental stages, as well as their knowledge of childhood-specific illnesses, medications, and therapies. In this, they echoed PNCB's pediatric nurse mindset constructs and phase 1 interviews. Several interviewees specifically mentioned the required mastery of different skills, techniques, doses, equipment needed to accommodate the patients, generally smaller in size, as well as their patients' wide range of ages, from infant through adolescent to late teen. Another vital capability of pediatric nursing professionals in hospital settings, as cited by many of the interviewees, was the capability to manage rapidly changing, high-stress situations calmly yet forcefully. Pediatric nursing professionals in these settings are focused on short-term, crisis-oriented, center-of-the-storm support for problem solving. They must therefore be adept at helping the family and child get through a crisis. In most cases, in the hospital setting, there may be less opportunity to develop long-term relationships with patients and their families. Despite the short-term focus, every interviewee also mentioned the intensely family-centered focus of pediatrics and the need to manage multiple complex relationships between healthcare professionals, parents, and pediatric patients. Most of the interviewees also mentioned the need for pediatric nursing professionals to be able to speak on different levels: child, adult, parent, healthcare team, all in the same setting at the same time. More than one interviewee talked about how much more difficult pediatrics is than in other areas of practice due to the wide ranges of patient development and multiple relationships that pediatric nursing professionals in particular must manage. One interviewee expressed it in this way: in a pediatric world, I think it's harder than the adult world because you are dealing with a patient who is a child who can have trouble expressing emotions. They're scared. You have to have not only the nursing skills to treat a child, infants, toddlers, 10-year-olds, preteens, and 18-year-olds, but on top of that, you are under the microscope of scrutiny. You add all that in, and then you have 2 parents sitting there in the room who are watching your every move, because that child in that bed is the center of their life, the center of their universe. In phase 2, it was validated that certification is a selling point for healthcare consumers and administrators, even if families are usually unaware of nursing credentials. Interviewees shared that consumers value the skill owned by certification and, of course, rely on hospitals to hire competent staff. Families experience the value of certification through optimized outcomes for their children. Several administrative stakeholders felt that having high percentages of certified nurses reflected well on the hospital and was a valuable selling point for patients seeking care at that hospital because it indicates that their providers are specially trained in pediatrics. One interviewee said that she actively promotes the fact that most of the nurses in her hospital are certified, believing that high level of certified nurses makes their hospital offer a higher level of care than that can be found at other hospitals who treat children in that area. One interviewee who is also responsible for hiring at her hospital said that if she were considering 2 candidates one with, one without certification, she would weigh heavily towards the certified candidate. In hospital settings, several interviewees place pediatric nursing professionals at the very center of the value network. Value flows outward from them to other providers, patients, and the hospital itself, and ultimately to the community. It was humbling and rewarding just to hear how valued certificates are. For the hospital setting, interviewees shared many wonderful things about pediatric nursing professionals, like they are the constant in patients' care and the bridge between providers. Other providers rely on pediatric nursing professionals to have the big picture and to fill the gaps in patient care and progress between providers' visits with the patients and between the providers themselves. The nurse practitioners in the intensive care unit are doing everything that the doctors are doing that they're allowed to under the law. They really are the backbone of the unit. Pediatric nursing professionals are also seen and valued by all of the stakeholders, providers, administrators, and patients, and the patient's strongest advocate. Although no patients were directly interviewed, several stakeholders with access to patient evaluation and advisory boards in their hospitals called out the nurse's role as a patient advocate as one of the most critical in creating value for both patient and the hospital in terms of good patient experience and optimal outcomes. Pediatric nursing professionals are also valued for their ability to interpret and communicate between healthcare team members and patients. One stakeholder likened nurses in this role to a team's traffic cop, directing care, instructions, and relaying information between various providers and patients themselves, the patients, parents, and the hospital administrators in an ongoing loop. Nurse practitioners in particular are also viewed as a central source for up-to-the-minute information and guidance for the healthcare team. Another interviewee noted that nurses are the glue that holds together the hospital. Everything rides on nursing. In the primary care setting, pediatric nursing professionals are links in a more linear value chain between patients and providers. RNs are frontline advice nurses, triaging patient care needs. Pediatric nurse practitioners are viewed as nearly co-equal to the physicians in terms of patient care, and they practice autonomously much of the time. Physician interviewees also noted that PNP team members knew they needed to consult about that they knew when they needed to consult about a patient. And this was an important mindset to have from both a liability standpoint and to give the PNPs and patients confidence. Certain aspects of acute care and complex patient needs are managed by the physician, for example, when stabilizing a child while waiting for an ambulance. Children with really complex needs or history are often scheduled with a physician. Nursing professionals are seen as the most adept at hands-on care and advisors to the other providers on procedural and practical skills. Primary care pediatric nurse practitioners in particular were recognized for being on nearly equal footing with medical specialists, and PNPs possess a rigorous and specialized knowledge of childhood developmental stages, illnesses, medications, and therapies. PNPs are trusted advisors who are cognizant of the child's environment. They consider the whole ecosystem of their patient in terms of the community, environmental hazards and food insecurity, parental or caretaker substance abuse issues, income-related challenges, and family trauma. PNPs are the motivators to influence children and families to make health changes and positive choices, and to follow and maintain prescribed treatments over both long and short term. In terms of our evolving pediatric nurse mindset, interviewees in both settings agreed on specialized pediatric knowledge. Differences surfaced between hospital responses stressing the need for mastery of technical skills versus primary care responses, elevating the aspect of pediatric specialization being on par with other medical and nursing specialties. A focus on family-centered care was evident in both settings, But hospital interviewees saw that focus through the lens of short-term, crisis-oriented versus the long-term relationships and deep understanding developed in primary care of where and how the patient lives, learns, and plays. This wasn't expected, but it does underscore that our certificates have different learning needs and that they rely and grow different competencies. We touched on the perceived value of certification, but there were differences between hospital and primary care settings, well-established perceptions reinforced through the interviews, like certification means proof of specialized competence, or that patients are not usually aware of credentials. These perceptions were shared in both settings, but hospitals, especially with large number of RNs on staff, focus on certification much more, from advancement to specialization to external influences like magnet recognition. Certification is very much an expected part of their culture. Both settings felt that certification validates at least a minimum competency in the specialty area. As expected, certification and recertification are required for nurse practitioners in both settings, but hospitals relied on nurses completing standardized steps on their institution's clinical ladder programs. In primary care, evaluations take place every 2 to 4 years. Chart reviews, case presentations, monitoring of interactions, and patient satisfaction surveys are all elements of their review process. For the two settings, interviewees expressed very different needs or expectations when asked about competencies for their nursing team members. Several hospital interviewees felt that there was a need for more training and expertise, specifically in communicating effectively with families. Several others spoke about team-based competencies, including collaboration and communication capabilities, specifically within a team-based environment. One interviewee stated that we need the care team to do a better job at being on the same page in an understanding and disseminating complex information that is continuously changing and coming from multiple sources. Multiple interviewees cited a need for training and expertise to treat the sicker, more critically ill, and more complex patients that are increasingly becoming the norm in the hospital setting. And other needed competencies relate specifically to the hospital in question, such as training in infectious diseases not seen in the general US population, mentioned by one of the San Antonio interviewees. This need was based on the presence of a large refugee center close to the hospital, which is treating 2 to 3 refugee patients at a time. Other site-specific needs were nurse competencies in epilepsy and post-surgical treatment of epilepsy and pediatric orthopedics, both of which related to their new children's hospital opening soon. In primary care, most interviewees agreed that it would be helpful if recertification and certification validated competencies in these areas. Mental health, particularly diagnosis and management of depression, anxiety, ADHD, eating disorders, suicide assessment, and substance abuse. Nutrition, particularly obesity and constipation. Motivational interviewing, trauma-informed care, asthma, autism, and X-ray interpretation. Apart from these notes in primary care, recertification did not surface as a major theme in the interviews. This gives us food for thought about how to make nurses recertification more meaningful or just even recognizable for the employer. So now we've formed hypotheses and Carly is ready to put them to the test with our certificates.
Our next step in our research was to invite all 50,000 certificates to give feedback in 2019. We introduced the pediatric nurse mindset, asked about research options, and more. The 27% response rate and 100 pages of write-in comments, certificates were interested and wanted to be heard. Here is our geographic breakdown of respondents. We felt this was a solid representation of our certificate base. Respondents had an average of 16 years of experience in the specialty. The vast majority provided direct patient care as expected, and 70% worked in pediatric subspecialty. When asked how they maintain their competence or indicate their continuing competence to others, continuing education clearly stands out. Active practice is the next highest activity for both questions, but by a wide margin. Teaching others made an appearance for both questions as well. When asked if their certification credential should convey to employers and healthcare consumers that you are competent in all areas of the initial board exam's content outline, approximately 50% felt this was not a requirement across all certificate segments. Career growth and subspecialization supersedes baseline exam content knowledge. Only PMHS respondents stand out with any significant support for being held to the exam content outline as a benchmark for their credential at 37%. When asked if hands-on direct care should be a requirement for recertification, a slight majority responded no. After revising our mindset through the construct and interview processes, we were glad to see that 83% agreed it is unique to pediatric nursing. Additional statements were also validated and open-ended comments were invited. After review of all of the responses, only minor edits were made, and the result was the statement you saw earlier with Adele. Next, we asked certificants how well PNCB research options contribute to their continuing competence. Clinical practice hours and CE clearly stood out. The second row option for our pediatric update modules are required CE activities for our pediatric nurse practitioners. Then we asked certificants what they felt was valued for evaluations by a supervisor. Recertification was the clear winner here, followed by skills demonstration. Competency assessment for high-risk activities and CE were ranked 3rd and 4th. However, when we segmented this data by the respondents and their certification type, it showed that recertification drops to the 3rd highest ranking activity among CPNs. CPNs gave higher weight to skills demonstration and competency assessment for higher risk activities than they do for recertification. As you can imagine, it would be difficult for a certification board to create a reliable evaluation skills demonstration or assessments for a diverse range of high-risk activities. But since these are valued, perhaps documentation for these activities that may be facilitated by the employer could be included as a research option in the future. Now it is time to ask what other options should be considered for measuring continuing competence. We know that other certification boards have implemented new assessments and some offer or require retesting. However, certificants highly rank documentation of employer assessments and CE guidance diagnostic tools. Next came the opinion that no further assessments were needed. Over a quarter of respondents were open to scored questions of the week or to situational judgment exercises to test critical thinking. Finally, we presented 5 potential research approaches to measure continuing competence in today's complex multidisciplinary healthcare environment. Continuing with current requirements was top ranked, followed by PNCB acknowledging specialization and PNCB requiring an objective self-assessment. Next, we needed to see if employers were in sync with certificates' opinions. Let's turn it back to Donna for those findings.
Thank you, Carly. Our strategy for this survey was to first ask certificants holding supervisory roles to respond, then invite a sampling of all other certificants to forward their survey to their supervisor or evaluating employer. We were surprised with the low response rate and a few upset emails that were seeking employer feedback about their individual continuing competence, even though the initial email was an invitation and it was clear that the goal was to understand what activities are valued and not to assess an individual's competence. We also branched out to include a small group of American Academy of Pediatric Physician lists. Since this survey was launched in mid-February, we knew that the pandemic was also a factor. Survey fatigue for certificants could also have been a factor. We paused the survey, then resumed it in September 2020 with the pediatrician list that was purchased. Unfortunately, we were unable to achieve our desired sample size of 400. Instead, we received a total of 209 employer responses to present today. While the final sample size and scope were less than robust than anticipated, the base sample data still provided a good preliminary level of insight into how those tasked with ensuring a competent pediatric nursing workforce perceive issues we were researching. The survey's goals were to understand how competence is demonstrated in the workplace, the perceived value of certification, if certification influences hiring decisions, and what unique competencies set pediatric nursing apart. Pediatric healthcare stakeholders who hire, supervise, and educate or evaluate pediatric RNs or PNPs were segmented by duties performed. Ensuring the competent nursing workforce accounted for 81% of the respondents' duties. When respondents were asked to rank the importance of activities to demonstrate RN continuing competence, the top 3 choices were skills demonstration, competency assessment for high-risk activities, and recertification. PNCB was reassured by the value placed on recertification, but note that it drops from the highest rank for certificants to 3rd place for employers. When comparing employer opinions on activities with RN certificate perceptions on what employers value, we found that the greatest variance between evaluation of team-based and/or leadership competencies, skill demonstration, and competency assessment for high-risk activities. When respondents were asked to rank the importance of activities to demonstrate PNP continuing competence, the top 3 choices were skill demonstration, competency assessment for high-risk activities, and medical record chart review. When comparing employer opinions with PNP certificate perceptions on what employers value, we found the greatest variance between evaluation, team-based, and/or leadership competencies, and medical record chart review, competency assessment for high-risk activities, and skills demonstration. This survey was also a great opportunity to explore employer perception of the value of pediatric certification. It was reassuring to see that 97% of employers agree that pediatric RN certification show that the nurse has gone to the next level and serves as proof of the special competence in pediatrics. In addition, 95% agree certification generates higher confidence in skills and knowledge among colleagues and is important in maintaining skills and knowledge. A total of 90% agree that a high percentage of certified nurses reflects that the facility provides better care and generates higher confidence in skills and knowledge among patients and families. We also asked about hiring preferences when 2 equally qualified RN candidates apply for a vacancy. 83% of employers prefer the RN with PNCB's certified pediatric nurse credential. We asked a similar question of those who employ, supervise, or educate PNPs and found that nearly 85% would most likely hire a PNP for their next pediatric team member vacancy over a family nurse practitioner or physician assistant, now known as physician associate. For nurse manager or supervisor segment, the preference for hiring a PNP peaked at 94.4%. Finally, to round out our validation of the pediatric nurse mindset language, 93% of employers agreed, which interestingly was higher than 83% of certificants. For our last segment, we'll turn back to Carly.
Thanks, Donna. Through our research, it became clear that growth in a nurse's role or career path through advancement, subspecialization, or other professional development needed special attention. At this juncture, we decided to develop a competency framework for pediatric nurses and validate it with our CPNs. It's important to note that this portion of our research pertains only to RNs. In the future, we hope to explore a framework with PNPs. The framework would inform and support pediatric nurses as they develop in their careers, maintain their certification, and enhance their daily practice. It represents 18 months of planning, execution, data analysis, and writing. We worked closely with a 13-member task force and conducted focus group sessions along the way. Specific goals for this research were to understand how nurses advance in their roles, provide a basis for updating the CPN recertification program in the future, establish benchmarks for individual nurses and student nurses when engaging in self-assessment and self-reflection during their personal career journeys, to assist RN faculty, clinical educators, staff development nurses, and nursing leadership in explaining career progression, setting goals with nurses, and evaluating nurses' performance to ensure a competent workforce. And lastly, to provide information that may be of interest to employers, hospitals, organizations, and human resources personnel for staff development purposes. Please note that the framework is a guideline, not a standard. It is not intended to be used for decision-making when hiring or evaluating nurses for promotion. Also note that a nurse's job title is not a limitation on what they can achieve. For example, a nurse does not need to be in a leadership role to reach leader competency milestones. A nurse also doesn't have to be in a formal role as a nurse scientist, researcher, or informaticist to reach innovator research milestones. Variables which can influence attainment of competency milestones could include, but are not limited to, organizational facilitators and barriers, or available scenarios in which behavioral progressions can be demonstrated. Examples of organizational facilitators and barriers might include access to resources, personnel, mentoring, staff development budgets, and emerging disruptors such as the COVID-19 pandemic. Components of the framework are competency areas along with their definitions. They cover broad and potentially overlapping areas of proficiency. Within each competency area are exemplars. These are brief statements indicating ways the competency manifests in behavior on the job. And finally, each exemplar has 3 levels of behavioral indicators. These describe what effective performance looks like at a particular proficiency level. Multiple proficiency levels in turn form developmental progressions, which are the anchor points of a pediatric RN's professional life. Before beginning this work, considerable discussion focused on creating anchor points for the 3 developmental levels. Anchors create consistency in behavioral descriptions both within and across competency areas. Level 1 was conceptually aligned with the beginning of pediatric nursing practice at about 1 to 2 years of full-time work. Task force members recognized that eligibility for the CPN exam fell within level 1. Levels 2 and 3 indicated experience levels roughly associated with mid-career and experienced pediatric nursing practice, respectively. In creating these levels, the task force acknowledged that not all nurses are expected to develop the same pace across all competency areas. There is no expectation that a pediatric nurse must perform at a specific level based on their years of experience. It is also not expected that all pediatric nurses will attain level 3 milestones in all competency areas or exemplars during their careers. A nurse with 2 to 5 years of pediatric nursing experience is not expected to demonstrate level 2 behavior. Developmental progressions associated with each exemplar are not expected to evolve in lockstep, meaning that if a nurse is a level 2 in one exemplar, it's not guaranteed or expected that they would be at a level 2 in all other exemplars. Finally, it's expected that behaviors from higher level milestones may start to emerge in lower levels, but performance of those behaviors will be demonstrated more consistently as that nurse reaches that higher level. It is understood that milestones are part of a continuum that starts during undergraduate education. Now we'll walk through the 6 roles of competency areas that were developed and validated. First, we have the clinician, who uses evidence-based practice, clinical judgment, professional engagement, and informatics to provide safe, patient and family-centered care for diverse pediatric populations. A pediatric nurse clinician engages in lifelong professional development to build and maintain competence. Second is the collaborator, who builds relationships with patients, families, and the team to identify needs and goals and incorporate these into decision-making processes. The pediatric nurse collaborator works with the interprofessional colleagues to assist in meeting optimal patient goals. Our third area is the advocate, acting on behalf of patients and families, nurses, communities, and self to improve, influence, and transform patient care, healthcare systems, the nursing profession, and social and political health-related policy. The fourth is the educator, who is engaged in the process of knowledge transfer at all levels of practice over the care continuum, while tailoring approaches to the needs of specific target audiences to achieve optimal outcomes. Our fifth area is the leader, who develops relationships and uses systems thinking in the workplace to guide and influence nurses and the profession, resulting in improvements in the provision of care and health outcomes. And finally, and to be honest, my favorite part of the framework is the innovator, who creates or adopts new methods, ideas, processes, or products through creative solutions and generates new knowledge through scientific inquiry. We hope you'll explore the framework in your packet more in depth. We think it's a great tool And you will see in our next sessions how we plan to use the framework with the CPN recert next year. Before we end this session, I'd like to point out some of our earlier notes within the behavioral indicators. Here, you will see our advocate competency area and its exemplars, levels, and behavioral indicators. The level 3 areas at bottom right, circled in blue, are the area that I want to focus on right now. Recall that we said that we don't expect all pediatric nurses to attain level 3 milestones in all competency areas or exemplars during their careers. These are two good examples of this. Not every nurse will have the time, the expertise, or the reach to become involved with policy and legislation at these high levels. Looking at the leader competency area here, the second column, we spotlight adherence to civility, diversity, and inclusion practices. This is a good example to illustrate our earlier note that milestones are part of a continuum that starts during undergraduate education. These topics are top of mind in undergraduate education, and we hope that level 1 starts well before 1 to 2 years of experience. We also want to illustrate the concept that a pediatric nurse need not be working in a leader role, a formal leader role, to attain level 3 behavioral indicators in this area. In the far right column are 3 behaviors I witness every day with many of my colleagues who have a variety of different titles and roles and often work at the bedside. Every nurse, every pediatric nurse can aspire to consistent high performance in each competency area, and they do. Thank you. And now I'll turn things over to Adele.
Hi, everyone. Thank you to Carly, Donna, and Amanda for covering our many years of work. You've really stepped up and made it so understandable for everyone. Thank you so much. It's really amazing to see it all condensed and connected in this way. So I'm going to speak to phase 5, the last phase of our ethnographic research. We closed out this research late last year by learning all we could about the various models of competency assessment used in settings around the United States. Interview participants represented a variety of supervisory, educational, and leadership titles and roles related to competency assessment and development. These included Professor of Nursing, Clinical Development Specialist, Clinical Learning Coordinator, Clinical Nurse Specialist, Director of Nursing Practice, and Magnet Performance Director, Magnet Recognition Program, and Pediatric Nurse Practitioner. We sought to gather data that will enable PNCB to build a framework for action based on the lived context of continuing competence, including certification. Our 2 hypotheses were that different models and methods of competence assessment used by institutions that employ nurses contribute to ongoing competence and can provide convincing evidence to allow PNCB to enlarge the scope of our recertification programs. Also, that there may be competency assessment models, techniques, or measurements that are unknown to PNCB, but they might prompt ideas for new recertification options in the future. We understood what certificates and employers valued, but we wanted to see how completed activities are ingested within institutions to contribute to individual nurse assessment and facility-wide standards. We also wanted to keep up with the times. Are there activities we could include in our research programs to create alignment between PNCB and employers? Have employers and other experts identified emerging trends that PNCB needs to keep on the radar? I wish we could share all the findings with you today. That's another rich report. There are some robust models and innovative ways employers are developing skills and knowledge of their nursing workforces beyond just portfolios and peer review. Some engaging examples are escape rooms, mistake rooms, competency fairs, interactive computer models, and others. We will consider how to share more of these findings later. You'll see how we hope to add one finding as a research option in the future with a little bit more discussion later. The rich qualitative data from phase 5 will certainly give us more to consider in the years ahead.